Specifically in my talk, because I know my colleagues will be talking about various forms of autoimmune encephalitis and antibody-mediated autoimmune encephalitis. So I thought I'm going to be focusing on another angle that I think needs a lot of emphasis, which is the link between neurology and psychiatry. After all, it's all one brain. And that specific link or bridge is neuroinflammation, immune dysregulation, and autoimmunity. So I'm going to focus specifically on cases where presented autoimmune problems of the brain or neuroinflammation of brain, presenting specifically with psychiatric problems, and that remain the dominant feature throughout the entire course of the illness, without progressing to focal neurological impairment or significant neurological deficit. And specifically, I'm going to be talking about autoimmune psychosis because I believe this is a sufficiently distinct class of brain disorders related to immune dysregulation, autoimmunity, manifesting specifically with psychiatric manifestation that remain dominant throughout the course and can masquerade as a new onset primary psychiatric disorder, such as the schizophrenia affective disorder, and mistaken obviously for that disorder. And I think we have a great number of patients presenting with this presentation with soft neurological findings, although the etiology is immune dysfunction or immune dysregulation or autoimmunity. So let me share with you my thoughts on that, and by first highlight the major links that proven in humans and animal models that link inflammation, so-called neuroinflammation, autoimmune dysregulation, and autoimmunity to psychiatric presentation in primary psychiatric disorders such as schizophrenia spectrum disorders, or even in autoimmune encephalitis. And as I said, autoimmune CNS disorders can present with psychosis that remain dominant throughout the entire course of the illness, without progressing to severe neurological deficit or focal neurological abnormalities. And that entity specifically we refer to as autoimmune psychosis. As you know, my colleagues and myself, we published a paper in Lancet Psychiatry a year and a half ago titled Autoimmune Psychosis, highlight the diagnosis and management of this type of disorders that presenting predominantly with psychiatric manifestation and specifically psychosis, to be distinguished from primary psychiatric illness. And when I use the word primary, I mean of psychiatric origin. What the term autoimmune psychosis imply secondary psychosis of immunological etiology. I know my esteemed colleagues, they're going to talk about various forms of autoimmune encephalitis mediated by synaptic autoantibodies such as anti-NMDA receptors, GABA receptors, and so forth, highlighted in this slide, in addition to transsynaptic autoimmune encephalitis mediated, for instance, by LGI1, Casper2, among others, in addition to intracellular antibodies directed against intracellular antigen, such as in paraneoplastic syndromes and GAD antibody and so forth. So in this slide, I'm just going to mention that, you know, there are rapidly emerging disorders of autoimmune encephalitis and continue to emerge every 2 years. A new antibody come in and still being characterized and so forth. So for a clinical practitioner, I mean, become clearly confusing. We as autoimmune individuals working in that field, when we suspect people who have autoimmune encephalitis, first you have to have high index of clinical suspicion. And then certain clinical phenomenology can help us thinking about one entity over other. For instance, if we think autoimmune encephalitis presenting with a lot of movement disorders, we think about an anti-NMDA receptor encephalitis. We think about autoimmune encephalitis related to LGI or Casper2, and now a newer antibody, we call it IGLNO5, which can present with Parkinson's disease-like pictures, specifically progressive supranuclear palsy and so forth. If somebody have a form of seizure, specifically called facial brachial dystonic seizures, we think about LGI. If somebody have unexplained hyponatremia in a setting of possible autoimmune encephalitis, we may think about LGI and Casper-2. A significant weight loss, we think about paraneoplastic causes. If we find teratoma in a setting of autoimmune encephalitis, we think about anti-NMDA. If we find delta brush, we think about anti-NMDA receptor encephalitis. So the clinical profile, paraclinical findings, meaning imaging EEG, as well as laboratory findings, can help us to narrow down what type of autoimmune encephalitis we're looking at. Why important to find antibody? First, you need to confirm diagnosis. That's number one. Number two, you know what the clinical course, what to expect, the prognosis, and what the treatment modalities. Third, you know about the comorbidity that can coexist with that disease. So for instance, if you think it's anti-NMDA receptor encephalitis, you're gonna look for ovarian teratoma. If you find antibody associated with MA2, you know it's paraneoplastic and specifically testicular seminoma. That's why it's really important to find antibody. But we know large number now, a rapidly growing class of autoimmune encephalitis that is really seronegative, meaning no antibody in the serum. And in those patients, subcategory of those patients, when you look in CSF, you find the antibody. That's why the final diagnosis really ought to be established by CSF analysis. But despite that, there are a group of autoimmune encephalitis that have negative CSF autoantibody panel. And that can explain by a variety of reasons. Among those, among many, that maybe the titer is so low, the antibody is already bound to their own respective receptors in the brain. Therefore, nothing much left to be freely floating in CSF. Or could be novel antibody, we don't know about it, and that's more likely. Or could be T-cell mediated, or maybe the autoimmune encephalitis is part of systemic inflammatory, with that specific autoantibody directly linked pathogenetically to etiology of autoimmune encephalitis. And as I said, today I'm going to talk about those categories that have no particular antibody, still is autoimmune related brain disorder presenting primarily with psychiatric illnesses. That's a specific category I'm talking about. And I think this is linked through multiple mechanisms, either due to include blood-brain barrier disruption associated with inflammation in the brain. And always the debate in literature is the inflammation precede blood-brain barrier or blood-brain barrier lead to the inflammation. I know there is a reciprocal relationship. I do believe that blood-brain barrier precede the inflammation among a lot of authors in the nation and international belief, probably that's what the etiology. But in addition to the direct impact of the antibody on the brain, I think there's a secondary pathology associated with autoimmune encephalitis caused by the antibody, which is blood-brain barrier disruption, in addition to the neuroinflammation. That neuroinflammation can cause neuronal injury. Neuronal injury in the brain in autoimmune encephalitis may be direct effects of neuronal antibody or indirect effects such as complement activation that leads to neuronal destruction. Certain autoimmune encephalitis has complement activation, others not. Example, anti-NMDA receptor encephalitis have no complement role in tissue destruction. In LGI, it does, and that's an example, for instance. Also, neuroinflammation associated with the pro-inflammatory mediators such as cytokines, matrix metalloproteinases, reactive oxygen species, and all that inflammation sometimes can be associated with neuronophagia. And I'm going to show you some histology showing the effect of the inflammation in the brain as a secondary phenomena caused by autoimmunity. So autoimmunity alone causes brain injury, and secondary inflammation in the blood-brain barrier by autoimmunity can accelerate brain dysfunction, leading to cognitive, neuropsychiatric features, as well as neurological deficit. But also, we should not forget about the dysregulation of neurotransmitters in the brain caused directly by the antibody or indirectly by the inflammation. And I will highlight those mechanisms. The final product and downstream of all those mechanisms is disconnection between several areas of the brain, so that we call functional disconnectivity, or sometimes create abnormal connection between areas that should not be connected. And that we found out in functional study, brain MRI studies, that such thing can happen and can lead to neurocognitive and neuropsychiatric sequelae. How inflammation can alter brain neurotransmitters? Well, multiple mechanisms. One of the mechanisms highlighted in this slide is the disruption of a tryptophan serotonin kynurenine pathway. Tryptophan is the precursor of serotonin versus kynurenine. It can go either way, often in a way of serotonin. Pro-inflammatory cytokines specifically accelerate conversion of tryptophan into kynurenine at the expense of conversion to serotonin. The end result is less serotonin. Not only reduce conversion of tryptophan to serotonin, but also accelerate degradation of serotonin into 5-hydroxyindole acetic acid. And that happens through enzyme called endolamine dioxygenase, 2,3-dioxygenase. And that's present in both glial cells, astrocyte, as well as microglia cells in the brain, which you know microglia is the primary inflammatory cell in the brain, although some of us consider astroglia part, obviously, of the neuroinflammation. That enzyme converts tryptophan to kynurenine rather than serotonin. But the downstream of kynurenine is the quinolinic acid, which is a strong NMDA receptor agonist. The end result is too much glutamate, less serotonin. Well, those are the established abnormalities in depression, among other neuropsychiatric. Therefore, it's not surprised why you have a lot of neuropsychiatric features, and sometimes can be the only manifestation in patients with autoimmune really disorders. In addition, obviously, the antibody itself can derange neurotransmitters, can cause derangement of GABAergic transmissions, such as antibodies against GABA A or B, or antibodies against NMDA receptors that alter glutamatergic transmission. Let me show a few cases about role inflammation psychiatric. This is a 35-year-old gentleman, work in a news agency. At one point, stopped working because of major depression that is refractory to all medications, to include ECT as well, and transcranial magnetic. Hospitalized more than 10 times in major psychiatric centers over the past 5-7 years, and came to me with major depressive disorder. Psychiatrists referred it. And the only reason why psychiatrists referred the patients to me because of a major psychiatric presentation that refracted to all treatment. And also there was some cognitive impairment. Depression could be associated with cognitive, but the cognitive impairment was disproportionate to psychiatric. So the end result, MRI essentially negative, CSF negative. We look for all antibody, no systemic autoimmune disease. We did the SPECT scan that showed hypoperfusion in the frontal region, and we did the brain biopsy. And the brain biopsy here on HNE, you don't see much really abnormalities. The arrows showing a little bit macroglia activation, but very minimal. But the finding was in electron microscopy. And this is at the top on the right, this is lower magnification. On the bottom lower part of this slide, that's higher magnification of EM, ultrastructure analysis of the blood vessels. I don't know if you're able to see my arrows, but I'm moving the arrow, but this is depicting blood vessels at the center. That's a microvessel, and that's endothelial cells, and there's a tight junction. And right at the arrow, you see those granules, the black arrows. Those are lipofuscin granules. Those are aging pigment, specifically located in the endothelial cells of the blood-brain barrier and around the blood vessels, disrupting the macrovessel of the brain. That means there's disruption of the blood-brain barrier. This is a leaky blood-brain barrier. This patient has leaky blood-brain barrier, and that type of leakage often missed by MRI imaging to include advanced technology. And CSF can be normal, serum can be normal, and that leading to progressive inflammation. And I just told you how the inflammation and the blood-brain barrier can contribute to neuropsychiatric features. And this slide here showing how the blood-brain barrier impairment can contribute to neurovascular. It's complex, so you can see neurovascular unit, endothelial cells, pericyte, as well as the astrocyte. Those are the main component of neurovascular unit. But in this complex slide, showing multiple molecules relevant to the inflammatory process, that's what happened in any inflammatory milieu. And those are cytokines produced by microglia. You see those yellow bubbles, those are reactive oxygen species. And you see the red bubbles, those are glutamate. And there's a lot of interaction between inflammation, reactive oxygen species, and glutamate. There's often bidirectional relationship, and the end results of the derangement of blood-brain barrier, peroxidation of the cytoskeletal protein of nerve cells, in this particular case, endothelial cells, and disruption of the endothelial cells. Now, the important things here that endothelial cells, which major component of neurovascular unit, are particularly involved or vulnerable to inflammation and oxidative stress. Why? Oxidative stress affect typically cells that has a prolonged life cycle and has a lot of mitochondria. Well, endothelial cells known to have very prolonged life cycle with high mitochondrial density. With inflammation and oxidative stress affecting endothelial cells, leading to disruption of blood-brain barrier, disruption of tight junction. In addition, obviously, cytokine itself can damage a blood-brain barrier and increase its permeability in a dose-dependent fashion. This disruption in neurovascular unit, I showed that you what appeared to be major depressive disorder as a primary, but can, of course, happen in autoimmune encephalitis. This is the case of anti-NMDA receptor encephalitis with the normal MRI, but the biopsy showed heavy inflammation localized around the blood-brain barrier. That's where you see it. Now, today we don't do at all brain biopsy, but this is one of the few cases early in the course of discovery of anti-NMDA receptor encephalitis before we know it is actually, in retrospect, it turned out to be anti-NMDA. But that's what you see in anti-NMDA receptor is perivascular inflammation, although we don't need to do biopsy anymore because now we have the diagnostic testing in the CSF that is very sensitive and specific. I said antibody can cause inflammation, and this is one case with voltage-gated potassium channel antibody back then, but now we know it's LGI. And despite the antibody is negative, and I truly believe it's LGI, initially the patient diagnosed to a possible tumor, because they thought the lesion on the left hippocampus is swelling. At that time, they did the testing for LGI was negative, and they thought still this is a tumor. Obviously, it was overlooked the lesion on the other side, as you can see here with the yellow arrow, that with the blue arrow, that this is actually autoimmune encephalitis. The end result, it was resected, thinking this is a tumor because it can mimic tumor, and the pathology shows inflammation. But I want to show you phenomena histologically can happen in autoimmune encephalitis, we call neuronophagia. So when you get the antibody and inflammation with macroglia and lymphocytes and histiocytes and macrophages can surround neurons. And you can see it here at the white arrows. Nerve cells surrounded by inflammatory cells eating that nerve cells, and that's what we call neuronophagia, one of the mechanisms of neuronal toxicity in addition to inflammation and reactive oxygen species. So here I want to highlight, then I talk about psychiatric disorders, I talk about autoimmune encephalitis, but now I'm going to limit it to the autoimmune brain disorders present purely with psychotic disorders, so-called autoimmune psychosis, because we believe there's a subgroup of patients currently diagnosed as a new onset of primary psychosis, meaning of psychiatric origin. A subgroup of those actually represent autoimmune encephalitis, to include anti-NMDA receptor encephalitis presenting solely with psychosis. What the size of that overlap or what the prevalence? Multiple studies look for prevalence of anti-NMDA receptor antibodies in psychiatric patients. And among those studies, we did one of ours, we published it in Schizophrenia Research. We did meta-analysis. The bottom line, in the interest of time, we found out people with psychiatric disorders have higher odds of NMDA receptor antibody seropositivity. Almost, they are three times more likely to have those antibodies. But those are different from the antibodies documented in anti-NMDA receptor encephalitis, and such that those antibodies typically either of IgG or IgM or combined IgG-IgM against NR1. In anti-NMDA receptor encephalitis, if you will hear from our colleagues, it is IgG against NR1 or blue N1. That's the other name. So it's a different category, a different immunoglobulin class, or different unit subclass of an MDA receptor can give you different clinical phenotype of autoimmune encephalitis. So let me share a few cases about autoimmune psychosis with seronegative and CSF negative. This is 26-year-old lady. I've seen her first at 21 years of age for a disease started at 15, characterized by monthly episode of encephalopathy with superimposed psychosis with the paranoia, delusion, as well as visual and auditory hallucinations. And with a cumulative episode, she developed progressive cognitive decline to the point when I saw her, her full scale IQ was 77, which is only in the 6th percentile. She had no focal findings. MRI was normal, and I'm going to show it to you. She has extensive workup, as you highlighted, to include serum and CSF autoantibody panel negative. The only finding was mild slowing, and that was it. The only thing was not done when I saw her is and that's the timeline showing progressive course. And as you see, I saw her at 21 years of age, and between 15 and 21 years of age, she already have 2 MRIs, and you could see those MRIs perfectly normal to include hippocampi. So the only thing was not done when I saw it was pro-inflammatory cytokines, and 2 of them were literally 40 times the upper limit of normal level. And those specifically IL-6 and TNF-alpha. And by the way, there's a relationship between those 2 cytokines. IL-6 can promote TNF-alpha synthesis, and TNF-alpha can promote IL-6. And both can derange the blood-brain barrier and contribute to inflammation. But that's the only thing we found out. ESR, CRP, everything normal. Based on that, and the cognitive deficit, we started immune therapy, and we have no antibody. And that's the treatment we give: pulse method prednisolone and monthly IVIG infusion. And you could see here really near complete recovery within 10 months. Insurances ask us to stop IVIG because I don't have antibody. What we're treating, and at that time we did stop it. And the end result, within a few months after we stopped it, there's a relapse. And now, after 10 years MRI normal, now you have a first-time abnormal MRI that's showing multiple signals or bright signal in the temporal lobe anteriorly, in the frontal lobe, parietal lobe, posterior temporal lobe. So for 10 years, this patient has a manifestation predominantly psychiatric with progressive cognitive, no focal neurological deficit, negative CSF, and negative 2 MRI. After 10 years, the MRI become abnormal. MRI is not sensitive for autoimmune encephalitis, and we know 75% of the patient MRI can be negative. Maybe later on can be positive, and this patient took 10 years. Now we treated obviously, and this is a biopsy to confirm it. So you see the blood vessels at the bottom right. You can see blood vessels that's hyalinized, thick. There's damage. That's what we see usually with hypertension, thickened hyalinized blood vessel. So this is another evidence of neurovascular unit disruption, surrounded by inflammatory cells, mostly T cells, which is CD3, barely I see B cells, CD20, which is the classical picture we do really see. So this is the list of immune therapy the patient had it over course of months to years. Unfortunately, none of them worked, despite the fact the MRI became normal, but the patient ended up with residual permanent cognitive neuropsychiatric deficit, and now the patient institutionalized. This is a prime example of what we call seronegative and CSF negative autoimmune, and the MRI negative for 10 years, despite the fact, and the presentation was purely psychiatric. This is a young lady presented with catatonia, no primary psychiatric illness, workup all negative. The only risk factor for her was her sister has MS, and for her, she had those tiny spots of bright signal, not classical for MS, but something happening. That was it. We treated her with IVIG and steroid, catatonia resolved, psychosis resolved, until this very day, had no relapses. So so far, it's monophasic disease thus far. It's been 5 years with no recurrence. This is another 18-year-old with abrupt onset of refractory OCD, motor tics, followed by psychosis with rapid cognitive decline. Again, the exam normal, workup normal, but the risk factors, the patient has a family history of autoimmune Hashimoto thyroiditis, and himself does have evidence of autoimmune disorders associated with this, to include POTS and adrenal insufficiency. And this is the PET scan, showed significant hypermetabolism in the frontal temporal region, and the treated patient with IVIG and steroid, and the patient achieved near complete recovery. Again, serum and CSF negative for autoimmune encephalitis antibodies. So this is another case of seronegative. Based on that, we said, there are those cases. We see them in our clinic. We do the workup, essentially negative. We do believe autoimmune. So how you make those diagnoses? First, you have to have high index of clinical suspicion based on red flag. And those are the red flags. Somebody have a progressive cognitive decline, very acute onset, rapid progression, unexplained, often inadequate response to antipsychotic treatment, or have adverse response. Those are red flags. Or focal neurological abnormality, of course, decreased level of consciousness, movement disorders, speech disorders, seizures. All those things can be red flag. And we met many people in Günzburg, Germany, roughly 3 years ago, and we come up with consensus. We called it international consensus about diagnosis and management. A consensus, because you know what, not many people have to agree on that, but we have to start somewhere. So that was a consensus about how we diagnose autoimmune encephalitis. We published it in Lancet Psychiatry. The bottom line, we come up with a classification. Proposed diagnostic criteria include possible, probable, or definite autoimmune. Possible autoimmune encephalitis, meaning the patient have abrupt onset with the rapid progression of less than 3 months, and has to include one of the following: either have disproportionate cognitive dysfunction, I showed you examples, adverse response to antipsychotic, unexplained new onset seizures, unexplained movement disorders, unexplained clinically significant autonomic dysfunction, decreased level of consciousness, or recent diagnosis of tumor. Those are red flags. So if you have that, in that setting, you can say this is maybe psychosis, not of psychiatric origin, possibly of autoimmune. Now you have to advance it to probable. Probable meaning you already met the criteria of possible, but in addition, you have to have one of the following: either CSF showing inflammation or MRI showing bilateral mesiotemporal. Or you have two of the following: EEG abnormality, spike, slow wave, epileptiform discharges or slowing to suggest organicity, or CSF showing oligoclonal bands but not nucleocytosis, or you have a presence of antibody in the serum. Presence in the antibody in serum does not make it definite autoimmune encephalitis. To make it definite, you must find it in the CSF, and that's the definition of definite. I know that's a conservative approach. I know despite that, we are missing patients with autoimmune psychosis because that does not cover all patients, but we have to start somewhere. We're afraid if we are more liberal, we're going to end up treating a lot of psychiatric patients who are really do not have autoimmune. So because not all autoimmune have abnormal MRI or frank neurologic abnormality or frank CSF abnormality. That's a reality. So you have to rely on red flags, clinical suspicion, paraclinical and laboratory findings, and try to come up with that diagnosis. So that diagnosis of autoimmune encephalitis, we believe, is a distinct class with distinct immunological footprints in the brain. Currently, in some patients can be presenting as what appear to be new onset primary psychosis, so we need to be careful. Diagnosis require high index of suspicion. We need to do more CSF studies as well. And you know what? I'm going to end up with the quote from Freud, and I think very relevant to what we're talking about, relevant to the bridge we're trying to build and the gap we're trying to close between two closely related fields, neurology and psychiatry. And that quote: we must recollect that all of our provisional ideas in psychology will presumably one day be based on an organic substrate. A lot of those cases called demonic possessions in the past. A lot of those patients locked up on psychiatric ward labeled as psychiatric or mental disorders. Some of those, I'm confident, they do have organic basis, and some of those patients with organic basis appear to be autoimmune. And that's why I'm defending the term of autoimmune psychosis.